introduce our speakers to you. Dr. Lindsay Jubelt is the Medical Director of Population Health at Mount Sinai Health System, where she leads the clinical program redesign across the health system. In her work, she aims to strengthen the health system's role as a learning laboratory to improve quality and value of care provided to patients. Dr. Jubelt is also an assistant professor of medicine and practicing general internist in a team-based primary practice at Mount Sinai Hospital. Dr. Jubelt received her BA from the University of Pennsylvania and her MD from Stony Brook University. She completed her internal medicine residency at Massachusetts General Hospital, followed by training in health services research via the Robert Wood Johnson Clinical Scholars Program at the University of Pennsylvania. Also wanted to make everyone aware of the upcoming speaking engagement that Dr. Jubelt will be speaking at the National Bundle Payment Summit, which will be held in Washington, D.C. at the Grand Hyatt on June 8th from 11:15 to 12:15, and her presentation title is Using Bundles to Engage Clinical Specialists. Also wanting to introduce Lee Jones, who is the CEO of GSI Health. GSI Health is a healthcare technology and solution company that provides integrated care and coordination and analytics, enabling the whole person care for complex populations. GSI Health is on the forefront of population health management solutions and has helped pioneer working models for effective collaboration and community-based delivery. Lee is recognized as an expert in healthcare information exchange and health IT more broadly, performing strategy development, business analysis, technical architecture, and solution design. He has assisted several states in the development of architectures and operational models for healthcare information exchange. Lee holds an MS in engineering and the management of technology jointly with Wharton School and the School of Engineering and Applied Science at the University of Pennsylvania, and holds a BS in computer science with Carnegie Mellon University. On the right-hand side, you can see the leadership and the variety of the industry initiatives that Lee has participated in. Just to name a few, the Federal IT Standards Committee, the National Longitudinal Care Coordination, which affects the support of the HL7s and the CCDA R2 standard, as well as the direct protocols, as well as others. As you can see, we are in for an enlightening hour with Lee and as well as with Lindsay. These two complement each other in their experience and their subject matter expertise as they bring forward to you what is taking place and how to dissect value-based programs and where do you stand and how to get there. Please welcome me in introducing Lindsay Jubelt and Lee Jones as we continue to move forward in our discussions today. Thank you so much for your time.
Yes.
If everyone would give us just a moment, we're having some technical difficulties, so just a moment, please, and thank you.
I'm just checking to see if folks can hear me on the line.
Lindsay, thank you so much for joining today. We appreciate your time. I'm going to go ahead and turn this over to you.
Wonderful. Thanks, Melanie. And are you able now to see my screen?
Yes, we can. Thank you.
Okay, great. So I'm going to start by giving you an overview of the Mount Sinai Health System and its transition to population health, why bundled payment is a good place to start in terms of transitioning to value-based payment, and how to develop a bundled payment product. So to give you a little bit of background on the Mount Sinai Health System, Mount Sinai is a large health system in New York City. We have 7 hospitals, a number of ambulatory care centers, over 37,000 employees, and over 6,000 primary care and specialty physicians. So we're a large health system. Mount Sinai went through a merger a few years ago, understanding that the move would be to population health to better position us to be in the right place to be able to take on financial risk. So nationally, we see this shift where providers are taking on more financial risk and the payers are partnering with us to give more financial risk to us. So we're moving away from fee-for-service towards bundled payment and capitation. So Mount Sinai really took the plunge in making this move. Last summer, it launched a campaign that was a full-page ad in the New York Times as well as the Wall Street Journal that stated, "If our beds are filled, it means we've failed." And this was really a statement to the region to say that we're taking on, in very serious ways, this move towards population health, investing in the health of the populations for the long term rather than the traditional system of making money off hospitalizations. And so with this, we are taking on increased financial risk of population. So as we move towards 2019, as you can see, we're going to have over 600,000 lives in contracts of which we will be at financial risk for them. And this really sets us up to be invested in the long-term health of patients. So as we've started making this transition, there are a lot of things that health systems need to take on that are different than what they had done traditionally. And as a result, we've launched a new group called the Mount Sinai Health Partners, which is the group that I'm a part of, which is where we are responsible for these new programs and taking on financial risk of patients. And so I think a lot of groups are struggling with how do we move into risk? What are the different elements that we need? First, I think it's important to recognize that you don't need to have all of the elements within your system or within your practice. Some of these things you can outsource, but I wanted to share a little bit about how we're restructuring to be able to move into the value-based payment world. And so these are a few departments within our group. So we've got our commercialization and product development. We've got our contracting office, our clinically integrated network administration. We have our clinical programs, our care coordination arm, IT, and then analytics. And so those are the departments. Of course, there are certain elements that we don't have within our department, such as legal and finance and some other marketing, and we rely on central resources for that. So not everything is within our group. So as we've thought about moving into taking on financial risk, there are sort of 2 ways to go. One is through bundled payment, and another one is through shared savings programs. So I wanted to talk a little bit about the differences of those 2 approaches and also where they overlap. So for a bundled payment, this is really talking about taking on financial risk for a unit, an episode of care. And so what you really care is about the unit cost during that episode. Where if you move into shared savings, you care about the total cost of care of that population. Bundled payment tends to be more focused on specialty care, and so it's a real opportunity to engage specialists in the value-based payment world, where shared savings is focused on primary care, and that's often where a lot of organizations start. Bundled payment, like I mentioned, is episodic, where shared savings is complete population health for however long the contract lasts, a year or several years. Bundled payment can coexist in fee-for-service because you're not focused on decreasing your volume of procedures. Instead, you're focused on lowering the total cost of care within that episode of care, where shared savings really is contradictory for fee-for-service. And another nice thing about bundled payment is that it allows for early adopters to solidify market position and attract payers. So if you develop a bundled product with a government payer, there's a lot of employers and commercial entities that are looking to get into bundled payment. So some folks have said that a practice or a health system needs to choose one or the other of these approaches, that they're really not the same. At Mount Sinai, we've taken on both. So we are in the Medicare Shared Savings Program, the MSSP program, and we're also engaged in bundled payment. And these programs have a lot of overlap. They both rely heavily on new data and analytics. You need to be able to know who your patients are and segment your patients by risk and be able to appropriately administer resources. You want to standardize care, whether it be across an episode or across the whole care continuum, as a way to reduce variation and lower costs. And then a lot of this has to do with care coordination. So where the fee-for-service system led to a lot of fragmentation, these payment structures really incent us to better coordinate care either across the episode or across the entire continuum. And so there are a lot of overlaps between shared savings and bundled payment. But I think it's because our CFO, because the bundled payment can coexist in the fee-for-service world, it's for that reason that I think he really celebrates bundled payment as a way to get into the value-based payment world. So another interesting thing is there was an article by the Hussey Group that was published in the New England Journal in 2009 where they looked at a number of different innovations in medicine, in healthcare, to see which are the ones that were the most promising to reduce healthcare spending. And out of all of them, by far, bundled payment came out as having the greatest opportunity at lowering the cost of care. So another reason that bundled payment is a great way to get into value-based payment is that it has the most promising ways of lowering spending. So just to do a little bit overview of what is bundled payment. So bundled payment is where you get a single payment for a group of services. And so where traditional fee-for-service, each of the services was paid for separately, in bundled payment you get a single comprehensive payment that is then shared between those different services. And this forces groups to come together to coordinate care across that episode. So bundled payment is really not a new concept. There have been a number of bundled payment demonstrations by CMS over the years. So in the early 90s, they had the heart bypass demonstration. They then had the cataract demonstration a little bit later on. In the 2000s, they had the ACE demonstration. And finally, in 2013, they came out with a bundled payment for care improvement program, the BPCI program. And then this year, in April, they launched comprehensive care for joint replacement, the first mandatory bundle. But even before CMS got into these bundled payment programs, one of the first bundles was in 1983, and that was the Inpatient Prospective Payment System, or the DRG payment system. And that bundled the cost of hospital care together into a single payment. And that was really the first example of a really big bundled payment program that became mandatory in our healthcare system and changed the way that we delivered inpatient care. So bundled payment of 2015 with the bundled payment for care improvement BPCI program really extended that DRG system to include not just the hospital stay, but the stay after the patient leaves the hospital, including the physician services, any post-acute care the patient receives, and if the patient is readmitted. So extended that episode of care beyond the hospital to the post-acute period. So CMS has led the way with a lot of the bundled payment. As I mentioned, they have the BPCI program. This is a voluntary program for which physician groups or post-acute facilities or hospitals can choose from 48 different clinical conditions based on families of DRGs that they want to participate in. It bundles both the Part A and the Part B, and the duration, one can select 30, 60, or 90 days. Payment can be prospective or retrospective, but most commonly it's retrospective. That means that everyone is paid still fee-for-service, but at the end of the day, there's a reconciliation where you look to see if your payments are less than what your target price was, and if so, you get to keep those savings. In April, CMS launched their first mandatory initiative, the Comprehensive Care for Joint Replacement, CJR, and this went live in a number of regions across the country, and it's for lower extremity joint replacement. It also includes Part A and Part B, and it includes the hospital stay for lower extremity joint replacement and a 90-day period after discharge. A number of states are starting to experiment with bundled payments, so you'll see Medicaid launch in various states launching bundled payment programs. Iowa and Arkansas are two of the leaders. But in addition to government payers, we're starting to see a lot of employers or plan sponsors and commercial payers that are interested in moving into bundled payment. So as healthcare costs are continuing to rise, employers and their workers are really feeling the brunt of this. And so they're really looking for opportunities that they can lower their costs, and bundled payment offers a great way to do this. And so you're starting to see commercial entities partnering up with physician groups or health systems to launch bundled payment programs. And this is where I think we're going to see a lot of movement in the market, which is very exciting. And this is where I think there's a lot of opportunity for folks to think about moving into value-based payment where they can compete with bundled payment. So I wanted to talk a little bit about the steps to develop a bundled payment product. And so there are 5 of them that I will go through. So the first is to establish disease priorities. So what factors to consider when you're thinking about where to start with value-based payment, particularly if you're going to launch a bundle program. So first, you want to make sure that you have a sufficiently large population with the disease. Invariably, there will be variation in costs and outcomes in any disease process, but that variation will be a lot greater if you have a small population. And so you can be a little confident in your that your costs will be more consistent if you have a sufficiently large population. Second is that you want to make sure that you have an opportunity to improve outcomes and lower costs. So you want to make sure that you're going into an area where you're already achieving excellence or where you have confidence that you can make improvements to achieve lower costs and better outcomes. You certainly need to have strong and supportive clinical champions to lead this. It cannot lead care redesign or launch a product without having a clinical champion behind it. In addition to physicians, you also want to have service line support, the support of the administrators as well as the staff on the ground that often are the ones that really get the work done. And then finally, you want to make sure that what you're developing overlaps with other initiatives of your practice or of the institution. As I talked about, there was a lot of overlap between shared savings and the bundle payment. There's a lot of overlap between bundle payment and readmission programs, many initiatives going on, and so it's important to think about where those overlaps exist. So I'm going to go into depth a little bit more about where opportunity exists to improve outcomes and lower costs. So one of the things to do once you start thinking about going into value-based payment is to look at your data and examine your variance within an episode of care. And so there is always going to be variance, but what you want to try to figure out is if there's an opportunity to decrease your variance, and that's really what you want. And so examine where your low-cost outliers are and your high-cost outliers, and try to understand why that's happening. You know, what's going on with those low-cost outliers? Could you change your processes to achieve more of those? What's causing your high-cost outliers, and are those preventable? Because what you really want to get to is this more narrow variance curve, because as you move into taking on financial risk, variance increases your risk. It's unpredictable. You could have too many high-cost patients that could cause you financial distress. So you really want to be able to narrow your cost curves, but also your outcomes for patients. You want to be able to deliver a predictable, high-quality product. So next, you want to try to see where do your costs fall relative to the market. So if your costs are above the market, as we move into a value-based payment world, this is not a good place to be, as commercial payers and plan sponsors are shopping around for who they want to partner with. If you're above the marketplace price, you better have a pretty good reason for why that is, because otherwise they're going to do business elsewhere. If you're the same or below the marketplace price and you have a good quality product, then you're in a great position to go out there and sell your practice or to sell your health system as a place where these folks want to do business. And they're looking for this now because healthcare costs are too high. And so if you're in a position where you can show that you're the same or below market price and offer good quality, you're in a great place to start getting into bundle payment and selling it on the market. So one of the interesting things when you try to figure out where you fall relative to the market is to appreciate that there is different spending across the country on Medicare and in the private insurance world. So this came from an article from the New York Times that was based on an article from Edinburgh Journal. And what you can see is if you were to lay these two maps on top of each other, the dark regions would almost be near opposite. So regions in the country that are high cost for Medicare spending often are not high cost for commercial spending, and vice versa. So when you're trying to figure out where you fall relative to the market, it depends on who you're trying to partner with, but remember that where you fall relative to the market may be different for Medicare as it is for the private insurance world. So the next step in thinking about moving into a bundle payment is to create an evidence-based, standardized care pathways across the system. And this is really where you have to roll these and get into the details. And so there's a lot of processes that have been in place, put in place in health systems or beyond health systems that have been in place for a long time that grew up organically and can probably be done better. And this is where you have the opportunity to reduce your variation. And so what we've done is go through and map out what happens each step along the way as the patient was walking through it, from before the hospitalization to the hospitalization to going home after the hospitalization or wherever they're going, mapping out what are the steps along the way. Is it the ideal way to do it, redesigning it if not, and ensuring that you're trying to have as little variation as possible. So I'm going to show you a little bit more detail. This is a pretty high-level flow diagram, but I'm going to show you a little bit more detail of what we get into. So this is a map that we mapped out just for patients at the point in time where they go home after a hospital, after joint replacement, and they go home with home services. This is the flow map for what would happen depending on what service they choose. And so it can get fairly detailed, and what we do is monitor these steps to make sure that they're happening and to determine how often folks are deviating from this pathway. Once you have identified the area you want to go into the disease process, you've started figuring out where your opportunities are to reduce your variation, improve your outcome. You really want to figure out a payer partner to launch this product with. And so I mentioned there are a number of government programs through Medicare and Medicaid. But like I said, health plans and employers are really interested in getting into the space because they're looking for opportunities to lower costs and have better outcomes for their employees. And so finding a payer partner that can work with you on this is important. Depending on what kind of partner you choose will determine how much work you need to do, but also how much opportunity there is for you to design the product. So if you move with a government program, those are fairly well structured in terms of the rules of the bundle program. However, if you were to partner up with an employer, often they're looking for you to design the product and work with them to come up with the rules. And so there's much more flexibility when working with a large employer than a government, and however, there's more work to be done. And so it just depends kind of where you are and wanting to design the product yourself or sign up for one that already exists. So when you're thinking about how to define a bundle, if you're designing one yourself, there are a number of things to consider. And the CMS programs have defined this for you already, a number of them. So first is the payment structure. Will it be a prospective bundled payment, or will it be retrospective and just tally up at the end? You need to define the bundle. So when does the bundle start? What is the event that begins the episode? Often it's a hospitalization, but it could be defined differently. How long will the bundle last, the episode last? And then what is in scope? So what services will be included in the bundle and what services will be excluded. The next thing is to define a fair baseline price. Doing this for the first time can be difficult if you don't know what the marketplace price is for a bundle, or if you're launching a new product within your market. Next is setting up some rules for data sharing. So working with your peer partner, you want to make sure that you're getting data and feedback so that you can make course corrections during the course of the program. You want to think about mechanisms to mitigate risk. So these include inclusion and exclusion criteria, which patients are would be included in the bundle, what are excluded, what services would be excluded, how can you do risk-adjusted pricing. So if you have a sicker patient, you get higher payment than if you have a healthier patient. We see this with the lower extremity joint programs from CMS. So they risk adjust for fractures versus non-fractures because fractures cost a lot more money for lower extremity joint replacements. And then having a stop loss cause. So some way if you have a very expensive patient that you won't be fully responsible for their full cost. Next thing to think about, particularly if you're working with an employer, is steerage. So could you launch a bundle with them and as a benefit be able to increase your volume if you provide good service, so they would steer more of their patients to you. And then finally, a termination clause. So if something were to not go as planned, that both sides have an opportunity to leave the partnership. So, all right, you've now defined your bundle and you're ready to implement. So this is where you want to think about having a site-based implementation team. So just like you need to have a clinical champion, you need to have that team on the ground that can really implement the program and have an implementation roadmap. You want to have a detailed process map outlining the entire care pathway. That's what I showed you with patients going home with home services. You're going to want to do this for the entire process, end-to-end pathway, and then have coordination of that episode. And you're going to monitor the adoption and adherence to that pathway. Just creating a pathway is one thing, but if people aren't adopting it and adhering to it, it's not doing any good other than just sitting on a piece of paper. So you want to make sure that you have a way to monitor adoption and adherence. And then you want to monitor coordination from the patient's perspective. So the patient is really the end user of the system and has the best perspective on how well this is going in terms of the coordination, so getting their feedback is key. For the who, so you want to have a single point of accountability for the clinical episode, as well as a single point of accountability for each task within the initiative. So as I mentioned, it's important to monitor the episode in specific process and outcome measures. So we set up an internal dashboard for everyone involved in our bundle payment initiative so everyone can see, are we on track? Are we doing what we're expecting to do and setting goals to try to achieve our milestones? We also have set up pathway reports to determine if folks are adhering to the pathways that we've created, and we email those out to the entire group and keep track of by individual and by team whether folks are adhering to the pathways. So the final step is to be able to evaluate the whole outcome of the initiative. And I think it's important to think broadly about these initiatives as you move into value. And so succeeding in a value-based contract, whether it be in shared savings or bundle payment, isn't just about the direct contract results. Absolutely, we all want to do well in these, but there's so much more that an institution should care about beyond just the direct contract results. So another important element, if we're thinking about the financial bucket, is the market share. So as I mentioned, one of the benefits of bundle payment is that you may be able to get steerage, increased volume to your hospital for some of these bundles, and so that's a great benefit. And so you want to be able to measure the effects of the volume change as well as the operational improvements that these programs are really driving. Next, you want to think about the internal operations, so monitoring quality and efficiency metrics, your physician alignment, and your health outcomes. So a lot of this care improvement is really going to drive you to have a much better quality product than you did before. You want to think about it from the customer experience. You want to use this as a way to be able to build stronger products for patients, to be able to track more patients in the future, so tracking what their experience is, as well as patient-reported outcomes. And so we're starting to put in place not just cost outcomes and traditional quality measures, but also patient-reported outcomes such as functional measures. How, are they able to walk after surgery? How far can they walk? And then learning and growth. So this moving into and developing new products in value-based payment gives us a chance in a health system or in a practice to identify new areas to improve and build new capabilities. As I showed on that early slide, there's so many new parts of our department that we've had to build in moving into this. And so that's a real strength in terms of learning and growth and readying the health system or the physician group to be ready to move even more into value-based payment. So starting these as initial pilots with the plan to learn and continue to grow is a great benefit for the organization. So I just want to thank you for the opportunity to be able to share our experience at Mount Sinai as we've started taking the plunge into value-based payment, and how bundle payment for us in particular has been a great way to start to dig in around specific disease processes and launching into some of this work of rolling up your sleeves, identifying variation in care across episodes, being able to fix it, create pathways, reduce variation, and in the end get to a product that is better outcomes for patients and lower costs of care.
Thank you, Dr. Jubel. This is Lee Jones from GSI Health, and I'll be giving the next presentation. And whereas Dr. Jubel was showing us a detailed case study around the bundle payments in particular and how they were implemented in the real world, so to speak, I'm going to be talking about this same idea of trying to bring in a value-based program and how the accumulation of those different value-based programs within a particular organization can be evaluated and managed. And so the idea here is to be able to have population health management become scalable. And so the topics I'm going to cover are a little bit about how to onboard, deploy, and evaluate a new value-based program with the idea that there will be a number of them that many organizations will have to deploy simultaneously, and to establish a framework for thinking about what is required. So first, a little about GSI Health and our context that shapes our perspective. We have a population health management solution that we deliver to our clients so that they can manage various kinds of populations under value-based programs or other analogous programs. And the content of our solution is comprised of care coordination and analytics, where a single platform can bring together the care coordination tools to enable care teams which may be federated and disparate, coming together as a single team to manage their common patients within a population of interest, and then analytics that allow the delivery of that care to be measured and analyzed and ultimately improved upon so that the care can continually get better. And so our perspective is really one that's shaped by the results and the activities that we see our customers having, as well as when we go into the marketplace and talk to a number of prospects, depending upon how they think about the different topics that I'm going to cover today, they have different requirements for our kind of solution, which is supportive of the infrastructure. So I believe that we all understand that the number and variety of value-based programs is expanding greatly. The horse is out of the barn, and many people have started, both on the provider side and on the payer side, to run full force into population health management and programs that are oriented around that idea. Certainly public payers and private payers alike have declared their intentions and have moved significantly in that direction, and providers have been taking on and committing to that direction as well. As Dr. Jubelt was talking about Mount Sinai, certainly we see that this is a real world example where there's a commitment to move toward risk-based models, and that is something that is continuing to proliferate. And so as that trend continues, the question is, will there be an ability for organizations to take on all of these various and sundry populations and have them coexist in a common care delivery model? And that's what I'm calling lateral scaling or horizontal scaling. When we're discussing our solution with prospects and customers, they're often interested in vertical scaling, which means, hey, I'm going to have a particular program, and I anticipate that the volume of patients who will come through that program will increase over time. And they want to make sure that whatever infrastructure they put in place can handle that increase for a particular program. And that's very important, but what's equally important is as they start to take on different kinds of programs, and those programs have to coexist, they may overlap in resources and infrastructure, overlap in care providers who are servicing them, and overlap in their patient populations that they serve. Will the infrastructure they put in place have to be duplicated across those programs and implemented in different ways, or is there a common core that can be strengthened so that they can effectively manage them and hone their population health management care delivery and apply it to multiple programs? And so we believe that the answer is yes, population health management can in fact scale laterally. If you focus on the shared infrastructure and you evaluate what you're doing according to the tenets of your care delivery model that you recognize up front is going to be shared across programs. And so every time there's a new value-based program taken on by an organization, there are a number of different steps that go into that decision. I won't try to cover all of them because I think that there are some nuances to each type of program and the way this program is implemented, but I will try to give a high-level overview on some things that need to be considered, especially when they have implications on the infrastructure that you'll put in place. So Dr. Jubelt gave us a specific example when it comes to a bundle payment product, and she talked about 5 steps that you can go through in order to establish that kind of program. I'm going to talk about some steps. They aren't chronological necessarily, but I think that they do have resonance with some of the points that she has brought out in her presentation, and when we come across those points, I will point them out. So the 3 things I'm really going to tell you about when it comes to onboarding, having a new value-based program is how to onboard one or figuring it out. How is it that you actually get it going, and then how to evaluate it. So in figuring it out, I was very encouraged to hear that Mount Sinai had really the forethought to put in an explicit organization that is managing and handling all of these new kinds of programs. And as she pointed out, it has a number of different dimensions, and all of these kinds of issues are things that are going to recur over and over again as you evaluate different programs at different times. And so while the process for any given program may vary, I think that the organizational structure that she showed and the point that's being made is having this kind of population health infrastructure so that each program can fit into what has been previously done is an essential way to think. And so I'm going to touch on just a few aspects of what one might consider, again, taken from the things that might impact the infrastructure that you put in place. One is figuring out the payment model. And so these payment models that are attendant to the different kinds of programs may have a number of different components. Fee-for-service may or may not still be a part of the equation. There may be performance incentives to perform certain kinds of activities like outreach, which get paid for explicitly. There may be some upside sharing of savings, gain share, or upside risk, if you want to think of it that way, and possibly, but in these days less frequently, some downside risk or non-performance penalty where there may be an opportunity to lose on what one might ordinarily expect based on your performance in the model. And what we've seen is that in these early days, there's often a blending of these different kinds of payment constructs. And in addition to just how the payments are constructed, there are also different models for how they're actually shared. And so it may be that all organizations who are partnering to accommodate a population health model may share in the value-based payment in some way. They all have an opportunity to bill and be compensated from that construct. It may be that there is a particular convening organization who is sort of the anchor tenant of any kind of collaboration among partner providers, and that convening organization is the one who actually has the relationship and has the payment, and they may have some individual financial arrangements with those participating organizations who agree to be their partners. Or sometimes it may be that that convening organization does not have a financial relationship that's specific to the program that they're implementing, but they have established relationships that cover a multitude of care delivery models. And because of those relationships, they, like a referral relationship, for example, they may have the ability to have partners without having them share in the particular value-based payment arrangement. I like the way that Dr. Jubelt talked about the payers as partners, and I believe that we've seen that thinking about the payers and providers being partners in this opportunity really is a beneficial way to think for many reasons. One, because of the constructing of an appropriate payment model, but when you get into actual care coordination activities, it really becomes important because often the payers want to participate in those care activities in some way. We're seeing that more and more. And so starting out with a partnership as opposed to just a funding mechanism is really an important way to think. And so in addition to the payment kinds of partners, there are also partners who will be delivering care services. And often this is across communities and geographies now as we move into these coordinated care models that are underpinning population health management. And so when creating these partnerships and these alliances, they have varying degrees of formality. And the further away from the convening organization that one gets, the less leverage that one has with the partnership. And that has implications when you actually are implementing the program in terms of compliance with the program's constructs, as well as the monitoring and availability of information and the ability to change and improve. And so if the umbrella or the convening organization has control over all of the participants, then obviously it's easier for them to anticipate and to manage those partnerships. It may be that they're not a part of the same sub-organization, but they may be part of a common parent, like a system may be entering into a program, and this system has employee physicians and other kinds of entities that they have some ability to implement a program and have better cooperation. It may be that it's a federation of different organizations, and those different organizations are contracted and have some direct financial incentives to participate in these kinds of arrangements. And because of that, you have some ability to have them to participate in an appropriate way. And at times it may be that they are a federated group, but they may not have the direct financial incentives, but have other kinds of incentives to participate, such as an increase in referral traffic and other things like that. And what we've seen is, especially when it comes to some of the larger population health management activities, patients can go where they want to go. And so there may be organizations that may not be explicit partners, but are part of the care fabric. And so they may not have specific incentives to participate in a particular way, but they may be able to be co-opted into the care paths that are put forth by the convening organization. What we've also seen is that in practice, there are usually a blend of these different kinds of partners who comprise the care teams and who are the delivery partners. And when we talk about delivery partners and providers, these could be providers of various stripes, whether they are medical or behavioral or social or other kinds of care partners who are part of the continuum of care. So after figuring out, or in addition to figuring out the partnership model, there may be program requirements. There's a lot of calculus that may go into what is an appropriate program for you, and Dr. Jubel touched on some of the considerations when it comes to bundled payments. Figuring out the program requirements will allow you to understand what kind of population will actually be impacted by the program out of the total patients that you encounter. And so there are a number of population considerations that may come into play. Is the population predetermined and known, or are they just meet some criteria as they come across your threshold? Lists given to you, or do you have to determine who should receive your services based on your full universe of patients? Are there any enrollment requirements or outreach requirements that have to be satisfied in order to participate in these programs? Are there any issues with consent or notification about the participation of patients in the program or eligibility requirements? This is just a sampling, but there are a number of different things that may impact the population that you're able to service with a given program, and that will impact the patient volumes that you need to have supported by your infrastructure, and so is a key planning consideration. There also, for any given program, may have specific programmatic considerations, such as are there required technologies that need to be integrated into the workflow, which may require additional roles or jobs to be created or taken on by organizations. There may be specific requirements to use certain data sources, and integration needs may come into play. There may be particular measures for payment or for evaluating quality measures, et cetera, and the timing of reporting and of delivering service, et cetera, may be important when you're thinking about what kind of infrastructure needs to be in place to support that program. Beyond figuring out the program, you have to figure out what the care delivery model itself is going to be. And by and large, organizations have either designed them to fit best practices that they've come across, or have come together to design protocols and pathways that are appropriate based on evidence-based medicine or other sources of authority. And so the idea of having a coordinated care plan is often central to these population health management initiatives. And the basis for a coordinated care plan might be any number of these things I mentioned, maybe evidence-based protocols. There may be designed pathways, as Dr. Jubel talked about. There may be local care delivery models that are already tried and true, as well as, for some populations, the ability to embellish upon those or organically design those coordinated care plans, which is put into the hand of a care manager or individual care providers. We've seen that there's often a blended approach when it comes to those things, but in addition to determining the basis of the care delivery model, there's how will the care coordination actually take place. And so one way is to have all of the care providers who comprise care teams to collaboratively contribute toward a coordinated care plan for a patient. And a number of programs have this as an objective, and it's sometimes difficult to do. There are issues that come up when it comes to where does the care plan live and what system creates it, and are there double entry or duplicative functionalities across different partners, et cetera. But I think as an ideal, the goal of having all of these care providers and a care manager contributing toward this same care plan is one that many strive for. There's also a number of competing models. One that I'll just call out is sort of a command and control model, where there may be one organization or one type of role, maybe that's the care manager, who is in charge of maintaining and developing the coordinated care plan, and they coordinate with all of the other members of the care team in sort of an out-of-band way. But they are the source of truth and the linchpin that holds the care team together, and they often are the ones who maintain and update and share the care plan appropriately while coordinating with the providers in a way that is more akin to what they are typically doing in their workflows outside of the value-based program. What we've seen happen in practice is that there's often a blended approach where there are a number of different care providers who may directly contribute to the care plan, and there are care managers who sort of bridge the gap for those who aren't able to for various reasons. And so a combination of these approaches is often used. And so as Dr. Jubel described, there's a marrying of the idea of a protocol, which may prescribe particular kinds of actions, and the idea of a pathway, where those actions need to be carried out by real-world entities and in a particular order and in a manner that can be managed and improved upon. And so she gave a more detailed one that was used at Mount Sinai, and she gave this high-level view that showed that the design of the various phases, in this case pre-hospitalization, hospitalization, and post-hospitalization, is an important consideration. So there are those kinds of things and a number of others I'm sure that you've all encountered that go into figuring out how you're going to bring in this value-based program. But once you have gone through those steps, you have to actually deploy it and have it operational. And so one thing that I thought was key that Dr. Jubelt mentioned is that you may have multiple programs that are going on, in this case bundle payment and shared savings, and they may have points that are orthogonal to one another and seem like they are entirely different programs, but in reality there is a common core and common infrastructure of things that they both will need to avail themselves of. And what I'm really trying to put forward today is trying to optimize that common core and infrastructure so that it can service whatever number of programs that you want to bring forward is a useful thing. And so to do that, it's useful to have a framework by which you can evaluate and construct these kinds of this kind of infrastructure so that it will serve you best. And so I'm going to put forward a framework. Certainly there are other frameworks that one might use, but this, for purposes of discussion, is one that we found useful in trying to think through how a particular set of infrastructure constructs may need to change by the addition of additional programs. And so I'll have 5 points in this framework. First, there's a tenet of population health management that I'll refer to as transparency, which is the people who are implementing a population health management paradigm need to be transparent with one another. You need to be able to understand what everyone else is doing and be able to communicate freely, and that's really the genesis of a number of the interoperability ideas that are going on. Second, you have to be able to coordinate what is happening among all of those different providers. How is it that you can control what's going on? And that's a combination of a number of different ideas, whether it's the establishment of teams or having enrollment and a way to understand the population to deliver tasking or have a care plan itself that governs how activities are going. If you can have both transparency and coordination, then you have what we think of as collaborative care. So now people are able to cooperate with one another and to do things that help move the ball forward, not just for oneself, but for the team, and have a greater understanding of what's actually happening. But before we can call collaborative care population health management, I think that there's another dimension that comes into play, which is the idea of continual improvement. And so continual improvement is comprised of measurement, being able to track and evaluate and synthesize information that flows through the collaborative care and is thrown off by that process, and it allows you to evaluate what's effective and what's actually happening. Beyond understanding what's happening, there is the idea of what should be happening based on what is going on and what you're seeing. And so the idea of solutioning to develop gaps in care or recommendations for care pathway or other things is under this idea of solutioning. And once you have ideas of what you should be doing and what is effective or not, you have to have the ability to facilitate change and understand what you can adjust in your collaborative care so that you can get better. So if you're able to have collaborative care and continual improvement, that brings about a robust population health framework. And so we will use these tenets as the basis for population health and to evaluate your infrastructure. And so having those tenets, we have some objects that they will apply to in the delivery of population health management. One, the obvious one may be populations, in as much as it is population health management after all. And so you want to manage an entire population, however that's defined, to collective health, meaning that there are measures on the health of the population that go beyond the measures of the health of any one individual patient. But in addition to managing the population, we want to manage the providers who are delivering care within that population. And they are a part of population health management to manage their activities, to make sure that they can work effectively as a team, and that they have all the resources that they need to do the best job possible. Similarly, we have to manage the patients who comprise the population and manage them all according to their individual needs, even though they are being optimized for the health of the population overall. And so we never forget about the patient as the end user of the system, as Dr. Jubelt called it. And then, just to continue with my P theme, you have to manage the entire panoply of these things together and manage them to the objectives of a particular program. And so having these objects of population health management and then being able to apply the tenets that we talked about in our framework means that you can ask the same series of questions about each one of them. So for each of these, population, providers, patients, and the panoply, you have to have transparency, coordination, measurement, solutioning, and an ability to change. And so you can ask what's going on with the population, but you can similarly ask what's going on with the providers, what's going on with each patient, what's going on with the entire program, and et cetera. And so with this kind of framework to sort of partition the different kinds of activities that may go into your implementation of a value-based program, you're able to segment and target where things may need to change and where things may need to stay the same as you add in a new program. So you figured out how to, or what program you want to do and how to implement that. And now when you're ready to get it going, you want to apply that program into, deploy it rather onto the framework that you've set up. And so as one example, you may have decided to have a bundled payment program, and you figured out your payment structure, and it's going to be a payment to the convener only. The partnerships that you have are leveraging relationships that are already in place through referrals and other things. The program is going to be episodic care versus a population more broadly, and there are various protocols and pathways that you've been able to develop, and it's based on, it's managed centrally in a more command and control manner, and it's based on evidence-based medicine and attendant augmentations of that. And so if this is the program that you have, then you can apply all of those different infrastructure components from our framework to implementing bundle payments, and it would then be configured for bundle payments, and you could, if this was the only thing you were doing, certainly optimize it for that course. However, if you want to add an additional value-based program, and this is where our lateral scaling begins, say a Medicaid health home, there may be different decisions that have been made for that program. When it comes to the payment, it may be a collaborative set of payments. The partnerships may have a blended model. This is dealing with a population that has to be managed and is distributed as opposed to people coming across the threshold in an episodic fashion. And there may be, because it's a Medicaid population, there may be much more control given to the individuals who are closest to the patient to determine what the care plans are. And so now the infrastructure that you have in place and have already invested in for a value-based program needs to be configured for multiple programs. And if you're able to partition it according to our framework, you can go through and identify specifically what areas need to be bifurcated so that they can accommodate differing needs, and then some things that will remain the same. And so the purpose here is, as you go to implement, you're not wholesale developing a new framework or a new infrastructure, but you're looking at your existing infrastructure, figuring out what things you're able to leverage because they are the same, what things need to change, and then hopefully in that changing, it can still be done in a similar fashion, so your workflows and all the other things that you've invested in to implement population health can be can be reused. And then finally, after getting the program going, you want to make sure that it lasts. And so this is really about trying to measure population health not according to the success of a particular program like bundle payments or a shared savings program, but trying to evaluate it according to certain hallmarks that you expect from it and the utilization of the framework and infrastructure that you have in place. And so you can implement an infrastructure in many ways, and infrastructure consists of a number of things, whether it's technology decisions and workflow decisions and other kinds of configuration decisions. Whatever it is for you that is making it work, that is sort of a part of your infrastructure. And you have to identify what aspects of the model that you're trying to put in place can be institutionalized and standardized, and that also is likely part of your go-forward infrastructure. So there are just a few hallmarks that we've seen as being important among our client base as they implement their own frameworks. One of them is having a cross-organizational care team that's performing the care coordination. And again, this care coordination may happen in different ways, whether it's command and control or fully collaborative or something in between. But in all cases, we've seen that the idea of collaborating and bringing together people who understand the goal that is around the patient who's classified by a particular program is important. Getting through issues around who is in your network and comprises the care team, or how the patients are assigned are certainly a part of that. And we've seen that most are really relying upon this care manager, care coordinator, and other names, titles that really speak to having a quarterback who really is in charge of making sure that the care planning happens in an appropriate way. And now we're starting to see a different phenomenon, which is different organizations implementing similar programs that have overlapping geographies and overlapping patients, and how is it that they collaborate and coordinate with one another in sort of an extended partnership. Unified care planning is also an important hallmark of your infrastructure to try to bring together the various activities that impact the patient that's going through the care management process that you've associated with your value-based program, and having that be the central place of reference for what's going on with a patient. People define care plans and plans of care in different ways, whether they are patient-facing or provider-facing or both, whether they contain particular kinds of instructions or other things. I think that at the end of the day, we've seen that the model that's taking hold is defining what the issues, goals, and interventions are around the patient, and whether those are facing the patient or facing the provider or both, but trying to understand what is supposed to be happening at that level, and then ultimately trying to validate that what is being done is appropriate. There needs to be transparency when it comes to having a care plan, but the care plan, most importantly, needs to be a prospective planning tool, not just a documentation of what has happened, but it's a plan on what is supposed to happen and what is going to happen so that it can be managed to a particular outcome. It's important to have insights that are derived from the delivery of care, and so analytics are often a part of this process, and analytics are certainly done in a number of different ways, sometimes being very separate from the care delivery process, where people in a back room are figuring out, looking at programs and figuring out what's going on because that's their competence. They may be data scientists or other people like that. Or it's closer to the delivery of care because they're putting the power of analytics and insights into the hands of people who actually have to manage the process day to day. And so, yeah, I think whatever model is being used, there has to be some consideration about the utility of the measures that are giving you insights and what you're actually looking at and trying to understand the data that you have to support it. Right now, there's a big focus on trying to predict through various risk algorithms what's going to happen with different segments of the patient population. I think as we get more experience as an industry, there will be a bigger emphasis on optimizing the operations and being more suggestive as to pathways can be improved as we gain experience with them. And then another key hallmark is that there has to be a technology-enabled workflow. It's just very impractical in this day and age with the amount of information that it needs to be moved around and the number of participants in a care team, particularly when there are chronic diseases involved or multiple comorbid conditions, et cetera, or lots of episodes that have to be managed simultaneously, to not have technology be your friend. And so this is always a challenge because every organization invests in its own set of systems and technologies to support what it does day to day. Often when these new programs come along, there's a desire to reuse things that are already in place versus others who think that it's better to put something directed toward these kinds of programs in place or some combination. There's often interoperability questions that come up, et cetera. There are all those things that I'm sure that this audience is used to wrestling with. We've seen that the state of the practice is to have something that is focused on care coordination that does not supplant the use of the electronic health record in the medical settings, but augments it by bringing a community view to and community coordination and care transition activities into the mix, and then to have analytics that are able to deliver insights at the ready and be supportive of what the care providers are doing. And at the end of the day, I think that there's enough variation in what providers and payers are doing and other kinds of considerations that there are always going to be many tools, and the challenge is to construct a single flow for your population health management activities through them. So then in summary, you should think about how to build a population health management infrastructure, whatever that means to your organization, and design it so that it can be leveraged repeatedly as you scale and get more sophisticated and entertain more and more of these value-based programs, especially in these early days when there is a lot of experimentation and new programs that are emerging. Look beyond just the success of any one program and look to see that there's adherence to the hallmarks and to the infrastructure as you define it, and use that to decide whether or not things are working well so that that wellness can be can accrue to not just the programs you have going at one time, but the ones that you'll have in the future. And then make sure that those hallmarks are in place and that they are operating well, and you have a way to measure them and think about them as you go forward. And so with that, I want to thank you for your time and attention. We will certainly turn to a question and answer period with both myself and Dr. Jubelt. And we'll also have some brief discussion between us about what's been presented. So prior to going into that, I guess, Melanie, I'll ask you to come back and repeat instructions for people to ask their questions.
Yes, absolutely. Thank you, Dr. Jubelt, and thank you, Lee, for wonderful information shared with everyone today. If anyone has any questions, please add those into the chat function, and the questions will be responded to. If we run out of time, then we will follow up with you directly and provide those responses to you. Lee and Dr. Jubelt, we do have questions in the chat area for you to respond to.
And so, Dr. Jubelt, are you on the line? Just want to make sure we don't have any unforeseen problems here.
Yes, I'm here.
Okay, great. Just wanted to make sure. So prior to going to questions, I wanted to just give you an opportunity if you had other thoughts based on what you presented and contrasting it with some of the things that I may have stated. Feel free to tell me, I don't know what I'm talking about. I can take that too.
No, Lee, I think you did a really nice job of broadening it out. What I gave an example of was really just, at Mount Sinai, how we've thought about approaching value-based payment and using the bundle payment as a way for us to start getting involved. But you did a nice job of, stating no matter what the programs are, there are so many commonalities, particularly when it comes to data analytics and care coordination, and how those are all important areas for all of us that we will continue to need to invest in and learn more from each other as healthcare continues to change.
Great. One thing that I wanted to ask you is just to make sure that we're all sort of clear. I was using pretty broadly this term, population health management, and in your presentation, you, when you were talking about bundle payments, made a distinction between population health management and episodic health management. Can you just explain what you mean by that so everyone is clear?
Sure. I think that was the slide comparing the bundle payment and shared savings. And so when I think about population health management, first of all, as a physician myself, I'm so excited about where this is going because I think it finally aligns the payment model to providing better care that isn't just within the four walls of our offices or hospital, but for the long haul, investing in patients for an episode or for years. So I think when you think about how you evaluate a bundle payment is that episode versus a shared savings or capitated program where you're thinking about your costs and your outcomes no matter how for the entire year or several years of the contract. However, I think all of these programs fall under the umbrella of population health management, which I really think starts with the shift in the payment model to align our incentives to care about the patients, again, no matter where they are, to ensure that we're investing in their well-being and trying to improve their health and outcomes.
Great, and I presume that part of the distinction is that with the bundle payments, and you can correct me if I'm wrong, the patients are sort of showing up and the episode begins and it sort of triggers the the bundle payments and pathways that you have associated, et cetera. Whereas in many of these other kinds of programs, there's a defined population that may already have certain characteristics that either you just treat as a whole or mine into in order to discover who should receive particular intervention.
Yeah, I think that's a great way to describe it. So yes, one of the perhaps parts that make bundle payments sometimes a bit easier is that, just as you said, that trigger for the bundle often is a hospitalization, and so you know exactly who those patients are, where in some of the capitation or shared savings programs, they are assigned to you or you're responsible for them for a variety of reasons. You have to do a little bit more work in terms of being able to figure out how to find those patients, because it's hard to manage patients that you aren't in communication with. So I think that's a nice distinction between the two.
Okay. There's one question that is in the that's been asked of us from the audience, saying what sort of system interoperability architecture is essential for the success of episodic care coordination? So maybe I'll toss that to you. Sure.
Well, I think that, Lee, you pointed this out. There's so much overlap and similarity between these two. I think with the episodic, the bundle payment programs, if the episode begins with a hospitalization, it has a lot more to do with building that transition program between the inpatient team and the outpatient world, so much more than what a readmission program, I think, has done. This is really about bringing your post-acute services and your community physicians onto the same team and developing a whole process of care for recovery and rehabilitation with that team together, that I think that for us was a lot of the work that we had to do. Was, we had great processes for the hospital, and we had maybe handoffs to a couple of the service providers in the outpatient world, but we really needed to develop that whole team of people and get everyone on board with developing what is the process of care for that entire episode, and ensure that everyone was participating in it, adopting it, and that we were measuring it and adhering to it. I think with care coordination with some of our ACO and our shared savings programs, that is much more about, I think, figuring out the needs of your patients and risk stratifying patients. We risk stratify within the bundle payment program and figure out who are our highest risk patients and provide a higher level of service for them. But I think with the ACOs, you're just talking about a much longer period of time, and so you really need to steward those resources thoughtfully. And so there it comes down to really being able to segment your population into those who are both high need, but for whom you think you can make an impact on by doing care coordination with them. But the other thing we've realized in our ACO is that even for them, hospitalizations present a great opportunity to make an impact. So we know that for patients who have had trying to predict a future hospitalization, one of the strongest predictors is having had a hospitalization. So within our ACO population, when they're in the hospital, that's a great group to go and build a relationship with. They're a captive audience, they're there, and so it's even there still that we use the hospital often as a launching place for care coordination. But I do think the differences are with the episodic bundle payment program, it's a lot about building new pathways into the outpatient world and care coordinating that transition and having that care coordinator really own that episode from the beginning to the end, where in the ACO program, it's a lot about needing to segment your population and really figure out who are those patients that would really both need and benefit from care coordination.
And in implementing those two different kinds of programs, are they both under the aegis of that organization that you described that you're a part of within Mount Sinai?
They are. Yep, they are. So all of our care coordination programs roll up within our department, and they serve a number of different programs, and so they can be scaled laterally, as you talked about, depending on how the program is structured and what the needs of the patients are.
And is there anything besides the existence of that organization that sort of does the planning for these different kinds of programs that you would consider part of a common infrastructure that these programs leverage?
So one of the programs that we're engaged with is the new oncology care model that CMS launched. And our group is doing the care coordination for that, but the clinical champions and the work and care redesign that needs to happen is really coming from the Department of Oncology. And so I think that as our entity, what we're realizing is we're really change agents within the organization. We can help departments or regions within the health system and health system or healthcare community, beyond Mount Sinai, start thinking about how do we redesign care, and we can provide some of that structure to do process improvement and change. But at some point, there's no way we'll be successful if our group takes it all on. And so we really need those partners, either internally or externally, to work with us. And ultimately, we will be the impetus to change, but they will be the ones that will really lead the initiative and take it on for the long haul. And so I think it's important when you're thinking about this to recognize that no matter how you structure your group, you won't be able to do it all, and that you're going to rely on partnerships. And so finding the right partners and those that you share a philosophy with and are trying to achieve, you have shared goals that you agree upon, and that at some point you can pass it off to them. We are not trying to recreate a separate healthcare system within our group. Instead, we're trying to serve as the levers of change to support our health system making those changes.
Great. Another question that has come from the audience is, what's the most efficient way to share information among these different partners without adding to their clinical documentation workflow, which I know is always a concern?
Yeah, that's a great question. So I think that's a lot, our group has really taken that on, recognizing that asking clinicians in particular to do more, there's so much of that going on. And so what we often think about in redesigning the process is how can we make their life easier so that they're getting a benefit from it? And so that's a very important part of this is as we redesign processes and create new care pathways, how can we take work off their plate? And then I think as we share data, as they're invested in the process, they really want to see, you know, how are we doing? Are we, in some of the process measures, are we adhering to the pathway? How are our outcomes? Are our patients, what's their satisfaction? And so they're actually quite interested in seeing the outcomes of their efforts when they're involved in the process. But a very critical part is trying to unburden those that are on the front line.
And that being one of the challenges, what are other things that you would count, and this again comes from the audience, as major barriers and challenges to achieving your population health management infrastructure and aims?
I think, you know, if I were to go back to the slide that talked about the 5 different steps of developing a bundled product, I think a lot of that can be applied to almost launching any type of population health management program. Each one of those steps, you know, comes with challenges. So first, looking at your diseases and trying to figure out the area. Well, you need to have your data in place so that you can look at it. And I think none of us are in a place where we have all of the data the way that we hope it to be, so that it's at our fingertips and it's in a user-friendly format for us to take a look at and analyze. And so that's a big struggle I think a lot of organizations are working through. Second is knowing, you know, where are your real strengths. So where are you doing really well from an outcome and cost perspective? You need to have comparisons. And so being able to get that information from the market in terms of where you're competitive and doing well. As you then launch a product, I think it's a lot of work to redesign care. It's not easy, and you really can't do it from a high-level conceptual framework. Those are very important to guide the care, but ultimately what you need to do is roll up your sleeves and get in there and redesign the process. Finding partners that you really do want the payment model to support this work. If you're redesigning the care that currently exists, it exists because it works very well in the fee-for-service system. And so if you're going to move and redesign care, you want to have a payment model that will reward the changes that you're making. And so figuring out which are the right payment models. As we went into bundled payment with CMS, we realized that we had some areas of strength clinically, but they just really weren't the right fits for that voluntary BPCI program. And so now we're taking them to the commercial market and selling them there. And so figuring out who are the right partners, and you need the payment model to support it. And then I think finally the monitoring process and outcomes. It's a lot of work to set up monitoring systems. And, we didn't have everything perfectly in place. We started small. We started with Excel spreadsheets that we emailed around to the teams to give them updates. And as we, had more time and investment in this, we eventually made it to a dashboard that people can access and realized that people weren't accessing it, and so started just pushing it out to people on a weekly, depending on what was the information, a weekly or monthly basis to their email boxes. But I think each one of those steps is challenging. And then I would say at the basis of all of this, having the right organizational infrastructure and support to do this change. And that is not something I think that any individual can do unless they are the CEO of or CFO of their organization. But being at a place that is supportive of this or trying to convince the leadership of the importance of this, I think that is really key if you're going to be successful.
Great. I think just embellishing a little on another question that's coming from the audience. In your presentation, you made an analysis about why bundle payment might be a great place to start. Do you see, as you've had experience with these different kinds of value-based programs and population health management programs, any normalization that you might predict in the future where some may fall away, or bundle payments, for example, become sort of the law of the land or the dominant kind of model? Do you see us moving toward anything that is common and other things falling away?
In terms of specific diseases or things other than bundle payments?
I think we now have, experimentation with different payment models and different ways to think about population health management. I just wondered if there's any normalization that you see on the horizon as these things get closer and closer to one another, or do you think that they're bound to be distinct and separate because they serve or exist for different purposes?
I think it is so exciting to see all of the different experimentation going on out there with different programs, and you probably have even more exposure to this than I do, and so I'll be curious to hear your thoughts on this question. But I think that there's no wrong answer here. I think it's good for organizations to get out there and try a lot of this, but I do think that CMS is the one that's really driving this home and pushing this, and I think they've indicated that they will probably make more. They've one mandatory bundle right now, and they probably will make more mandatory bundles, and this may just be the way that we start paying for care for certain conditions. And so we may start to see some unifying themes that CMS is pushing that we will need to adopt. But I think it's a great question. I don't think it's been answered. I do think that the more experimentation, the better. I think then the other pressure comes from the commercial and employer world, where healthcare costs are just too high for them. And whether you look at from their perspective, their employees, or whether you look at CMS and the Medicare population, there are certain disease conditions that are just big drivers of this and comprise a lot of the cost. So if you think about the big five, which are oncology, GI, ortho, cardiology, and maternity, I think we're going to see programs in those areas because that's where the costs are. And so a lot of those may lend themselves to bundled payment because a lot of the costs come from procedures and episodic type phenomenon. And so I think that I would guess that we'll see more experimentation in bundled payment, both from Medicare as well as from the commercial side. But I think that the experimentation and the programs that are out there is really great because I think no one has the answer about what really is going to work. But Lee, I'm curious from where you sit in the amount of experimentation and different organizations' approach to this. What do you think about what's going to happen?
I actually am in a similar camp as you. I think that doing something is better than doing nothing, and so I like the fact that there's a lot going on and a lot of people trying lots of things, and with that understanding that there will be successes and failures, but always opportunities to learn. I think that I doubt that there would be one master program that'll sort of cover everything. Because I think, as you're pointing out, some of these programs are oriented around, most easily oriented around disease states. Others are oriented around particular populations that exist because of some circumstance like Medicaid or Medicare. Other things, make sense in other contexts. So I think what seems to be standardizing is what I was trying to point out, which is the way that, to the extent that organizations are going to be dealing with these things all at once, to institute things that are standard practice is what seems to be an opportunity for us to have some commonality. And that's where I think establishing the common pathways, standard pathways like you were discussing, or the emergence of the care team and care plan is being central to a number of these things. Those kinds of things I think will start to standardize and be more common, and the way that organizations get paid, or the way that populations are defined, and particular measures and metrics, et cetera, I think will continue to vary by the circumstance. So I think, just looking at the time, we have to leave it there. So let me personally thank you, Dr. Jubel, for your insights and for your example that you gave today. And I'll turn it over to Melanie for any wrap-up and final final instructions.
Thank you, Lee. Again, thank you to Dr. Jubel and to Lee for your time today and for interacting with our audience to share relevant information in regards to what's happening in the market today. For those that have attended, you will receive a link to the webinar as well as an overview document to share with you the information provided by Lindsay and Lee today. If you have additional questions, please do not hesitate to reach out to Lindsay or to Lee or to myself. We look forward to having any further discussions with you that you may need. Again, thank you for your time, and please keep a lookout for Lindsay and Lee out in their speaking engagements, and as well as additional series for webinars that will be announced in the next month. Have a great afternoon. Thank you so much for your time.